Jaundice. Introduction. Jaundice in adults is very rarely due to a prehepatic cause, e.g. hemolysis, hepatic, e.g. parenchymal disease, or posthepatic, e.g. biliary obstruction. Causes are most likely, tables 23 and 24. History, examination, and liver function tests usually give a good indication of which of these broad categories applies to the patient, but liver ultrasound is virtually mandatory. Dilated common and intrahepatic bile ducts indicate obstruction. Parenchymal liver disease is more likely if the ducts are normal-sized, in the absence of pain. History of the presenting problem. NB. Not all jaundice in the alcohol abuser is due to alcoholic hepatitis. Important features to pursue include the following. Pain. The presence of pain can indicate obstruction of the common bile duct, CBD, with a stone. Carcinoma of the pancreas classically presents with painless jaundice. Parenchymal liver disease occasionally results in right upper quadrant discomfort due to stretching of the liver capsule. Weight loss. An ominous symptom that may indicate pancreatic carcinoma or cholangiocarcinoma. Change in color of stool and urine. In obstructive jaundice the stool becomes paler, because bile is unable to flow into the intestine and color the stool, and the urine darker, excess conjugated bilirubin. Remember, however, that similar, though less extreme, changes can also occur in parenchymal disease because inflammation of the liver parenchyma can cause local obstruction of the bile canaliculi and interlobular bile ducts. Fever. Together with pain and jaundice forms Charcot's triad, which is characteristic of ascending cholangitis due to bacterial infection in the biliary system. This is usually a complication of CBD stones and rarely occurs with pancreatic carcinoma. Other relevant history. Alcohol history. The details given in this clinical scenario clearly indicate that alcohol may be the cause of the problem, but this possibility is often concealed. Sometimes a history that includes head injuries, rib or other peripheral fractures, unexplained epileptic seizures, recurrent acute pancreatitis and/or gastrointestinal bleeding can suggest long-standing alcohol excess. Without causing offense, you need answers to the following questions if the information does not emerge without prompting. When did you last drink any alcohol? Do you drink daily or binge drink? Have months alcohol-free? What type of alcohol do you drink? Spirits? Beer? How much do you drink each week now, and how much in the past? Figure 22 allows you to calculate the number of units. Have you ever been told you have an alcohol problem and told to stop drinking? NB. The CAGE questionnaire can be a useful aide-memoire for confirming suspicion of alcohol excess, particularly if the patient denies having an alcohol problem. With respect to drinking, ask the patient if he or she has ever C. felt a need to cut down, A. been annoyed at the suggestion of a drinking problem, G. felt guilty about your drinking, E. had to have a drink, eye-opener, in the morning. Relevant past medical and surgical history. The details given here state that the patient has had a cholecystectomy, but it is always relevant to ask jaundiced patients if they are known to have gallstones. Patients can still have retained stones in the CBD despite cholecystectomy, as well as forming new stones in situ, and jaundice can develop as a result of inadvertent biliary or vascular complications following cholecystectomy. NB. Cholecystectomy may present sometime after previous cholecystectomy for gallstones. This may be due to silent stones having been missed in the CBD at the time of operation, or possibly formation of new stones in situ. Drug history. It is essential to determine details of all prescribed and non-prescribed medications used by the patient in the 6 weeks before jaundice developed. Apparently innocent medications can cause drug-induced hepatotoxicity, common culprits including Augmentin, co-amoxiclav, and ibuprofen. Herbal and Chinese medications have also been implicated. Travel history. Travel is a risk factor for jaundice. It is essential to know if patients have been abroad to a country where hepatitis A or hepatitis E is endemic, also if they have been in contact with anyone else with viral hepatitis. Other causes of liver disease. It is important and appropriate to take a sensitive history relating to previous intravenous drug abuse and a thorough sexual history. It is also relevant to inquire about a family history of liver disease. Previous blood transfusions. A history of childhood jaundice or a history of pregnancy-associated jaundice occasionally give contributory information. Is the patient developing hepatic encephalopathy? A history of any change in the ability to concentrate, e.g. read the newspaper or do the crossword, can suggest early hepatic encephalopathy, as can reversal in the sleep-wake cycle with daytime sleepiness. Examination. General features. As always when dealing with an acute case, the first priority is to decide if the patient is well, ill, very ill or nearly dead, and to begin resuscitation and get help from the intensive care unit immediately if required. Then, in a patient presenting with jaundice, consider the diagnoses listed in tables 23 and 24 and look for evidence of sepsis, fever, tachycardia, hypotension, confusion, malignancy, cachexia, lymphadenopathy, chronic liver disease, alcohol withdrawal, agitation, hallucinations, tremor, hepatic encephalopathy, Wernicke's encephalopathy, nystagmus, ophthalmoplegia. Abdomen. Look in particular for evidence of the following: scars, previous cholecystectomy, previous resection of colorectal malignancy, previous surgery for pancreatitis or pancreatic carcinoma. Liver. Usually firm, tender, and enlarged up to 10 cm in acute alcoholic hepatitis, may be irregular if there is associated cirrhosis, but firm irregular hepatomegaly must raise suspicion of malignancy, primary or secondary. A hepatic bruit may be heard in severe alcoholic hepatitis as well as with hepatocellular carcinoma. Splenomegaly suggests portal hypertension in this context. Gallbladder. If palpable, remember Courvoisier's law, which states that in the presence of jaundice an enlarged gallbladder is unlikely to be due to gallstones. Carcinoma of the pancreas or the lower biliary tree are more likely. Ascites suggests chronic liver disease or malignancy. Melena indicates upper gastrointestinal bleeding. Investigation. Routine blood tests and CXR. Check FBC, electrolytes, renal, liver, bone profiles, clotting screen, blood cultures, group and save. The pattern of abnormality on liver function tests is used to distinguish between a hepatitic process, raised alanine transaminase (ALT), and an obstructive biliary process, raised alkaline phosphatase (ALP), although distinction on these grounds is not infallible. The CXR may show evidence of lung cancer or metastatic disease. NB. Gallstones can present acutely with ALT higher than ALP, and in end-stage liver disease liver enzymes can be normal. Ultrasound examination of the abdomen. The key imaging test is ultrasound examination of the abdomen to help differentiate between hepatic and biliary causes of jaundice, and to provide evidence of chronic liver disease and portal hypertension. liver, gallbladder, and biliary tree. Appearance of the liver parenchyma, fat infiltration, heterogeneous suggesting cirrhosis, focal lesions such as new hepatoma, intrahepatic and extrahepatic biliary ducts, dilation, gallbladder, stones, thick-walled suggesting inflammation, liver vasculature, portal vein thrombosis, hepatic vein abnormalities. Pancreas, not always well visualized, but is there a focal lesion? Spleen, enlargement suggests portal hypertension in this context, splenic varices may be seen. Ascites, consistent with portal hypertension or malignancy. NB. In the patient presenting with obstructive jaundice, consider the following. Gallstones. Pancreatic carcinoma and cholangiocarcinoma, usually painless. Pancreatitis, edema and swelling of the pancreatic head can compress the bile duct. Budd-Chiari syndrome, acute hepatic vein obstruction results in painful hepatomegaly, ascites, and jaundice, usually mild. Further blood tests. These will be dictated by clinical suspicion and by the results of the routine investigations described above. If an acute infective hepatitis is thought most likely, then testing for hepatitis A, B and E, cytomegalovirus, and Epstein-Barr virus will be appropriate. If it is thought that the patient has chronic liver disease, then investigation should be pursued. Further imaging. If there is a focal lesion in the liver or pancreas, then an abdominal CT scan should usually be the next investigation. In contrast, if ultrasonography suggests biliary pathology, then either endoscopic retrograde cholangiopancreatography, ERCP, Fig 23, or magnetic resonance cholangiopancreatography, MRCP, Fig 24, is indicated. In centers where both of these tests are available, ERCP should only be performed if it is likely that a therapeutic procedure is likely to be performed because of the associated morbidity and mortality. Tissue biopsy. Broad indications for a liver biopsy are when the etiology of liver disease is unclear, where the degree of liver damage determines the treatment, e.g. hepatitis B or C, autoimmune hepatitis, or where the nature of a focal lesion is unclear. NB. Liver biopsy carries a significant risk of bleeding. The British Society of Gastroenterology suggests transjugular liver biopsy if the platelet count is less than 40x109/ln or the prothrombin time is prolonged by more than 6 seconds. Management. If the patient is very ill, then resuscitate. Specific management will depend on the diagnosis. Cholangitis. NB. Urgent drainage of the biliary system is required in acute ascending cholangitis with obstruction. If the patient has high fever, rigors, or is obviously septicemic, then treat for septicemia with the working diagnosis of ascending cholangitis. Most commonly gut organisms are the culprits, e.g. Escherichia coli, Klebsiella, and Enterobacter species, Enterococci and group D streptococci. Antibiotics with broad-spectrum cover should be given in accord with local antimicrobial guidelines, but these would typically comprise a third-generation cephalosporin, a quinolone such as ciprofloxacin or an anti-pseudomonal penicillin such as piperacillin and tazobactam, tazocin. The patient with an obstructed infected biliary tree will not get better until the obstruction is relieved. Insertion of a stent allows drainage around stones and can produce temporary clinical improvement in the ill patient with deranged clotting. Alternatively, sphincterotomy and stone extraction may be achieved at initial endoscopy, Fig 23. Cholecystectomy is usual at a later date to remove the focus, unless comorbidity and frailty dictates otherwise. The alcoholic with jaundice. The patient with jaundice in the context of alcoholic liver disease can be difficult to manage. If the patient deteriorates in hospital, the prognosis is poor. Progressive liver failure may develop with rising prothrombin time, increasing jaundice, encephalopathy, gastrointestinal hemorrhage, varices or gastropathy, and hepatorenal failure despite abstinence and good supportive medical care. Early active treatment is essential, as is early referral to a hepatologist. Important aspects of treatment include assessment of prognosis based on clinical presentation and previous history of alcohol use, careful attention to fluid balance, scrupulous diagnosis and treatment of infection, aggressive nutrition, and prevention of alcohol withdrawal. Corticosteroids are used by some in the treatment of alcoholic hepatitis, but the timing and selection of patients who should receive these are controversial. UK liver centres do not offer liver transplantation for acute alcoholic hepatitis, and those with chronic decompensated alcoholic liver disease need to demonstrate 6 months abstinence and a commitment to lifelong alcohol avoidance. NB. Have a very low threshold for administering intravenous thiamine to any patient at risk of thiamine deficiency. The consequence of untreated or unrecognized Wernicke's encephalopathy are very serious. NB. Accumulation of sedatives occurs in the presence of alcoholic hepatitis and/or cirrhosis, and there is a risk of precipitating encephalopathy. Review dosing on a daily basis and stop if the patient becomes drowsy.